All right, future nurses, welcome to the deep dive. Ever felt that little knot in your stomach when you think about mastering lower GI problems for your exams and maybe more importantly for the patients you'll actually care for?
It's a huge topic, definitely.
Yeah, so today we're trying to cut through some of that noise.
Yeah.
Our mission is to take this massive chapter from Lewis's 12th edition on the lower GI and really boil it down.
Let's distill it to the essentials.
Exactly.
Yeah.
We want those key actionable nuggets of knowledge, the pathophysiology, the risk factors you need to spot, those clinical signs, diagnostics, and of course, the nursing management that makes you truly well-informed.
Sort of an express lane to the aha moments.
That's the goal, designed for you, the learner, without getting totally bogged down. So let's unpack this.
Sounds good. And, what's really interesting here is how many concepts actually weave together. We're talking cellular regulation, elimination, obviously, but also fluids, electrolytes, nutrition, inflammation.
Pain, even stress and coping.
Right. It all connects to impact of patients' bowel habits and nutritional health.
Okay, so whether you're prepping for clinical, studying for the NCLEX, or just really curious, let's connect those dots and see the bigger picture of lower GI health and how you fit into that picture.
Let's do it.
Let's dive in, maybe starting with those common elimination issues, the ones that, seem simple but can escalate fast. 1. Common elimination issues: diarrhea, fecal incontinence, and constipation.
Okay, kicking things off with diarrhea. And like we said, this isn't just loose stools, right? It can become a serious crisis.
That's absolutely right. The basic definition is 3 or more loose or liquid stools per day. But yeah, while a lot of cases are self-limiting, the real concern for nurses, especially in healthcare settings, is often that acute infectious diarrhea.
And the big one we have to talk about in hospitals is C. diff, isn't it? Clostridioides difficile.
Oh, definitely. CDI. It's such an opportunistic bacteria. It really thrives when broad-spectrum antibiotics just wipe out the normal gut flora.
And the outcomes can range pretty widely.
They can, from fairly mild diarrhea all the way to severe colitis, even toxic megacolon, which is that rapid expansion and potential rupture of the colon.
Exactly. A true surgical emergency.
So this brings us straight to a critical nursing takeaway, doesn't it? Infection control for C. diff.
Paramount. Meticulous hand washing. And it has to be soap and water.
Right, because alcohol-based sanitizers don't kill the spores.
Correct. They're ineffective against the spores. Plus, patient isolation and disinfecting surfaces properly, usually with a 10% bleach solution. These are non-negotiable.
Okay, so beyond stopping the spread, what are the nursing priorities for a patient with severe diarrhea?
Number 1 is preventing those life-threatening complications: dehydration, hypokalemia, low potassium, and metabolic acidosis.
So that means really vigilant fluid and electrolyte replacement. Oral if they can manage it, IV if not.
Yes. And don't forget skin protection. That constant moisture can cause really rapid perianal skin breakdown. We need barrier creams, maybe sitz baths, easy access to toileting.
And what about antidiarrheal meds like loperamide?
You have to be careful. For infectious diarrheas, especially bacterial ones, they're often avoided
Why is that?
because they can actually slow down the gut motility and prolong the body's exposure to the pathogen. In IBD, there's also a risk of triggering toxic megacolon, so it's not always the right move.
Got it. Okay, so from things moving too fast, let's switch to when control is lost. Fecal incontinence, the involuntary loss of stool.
Yeah, and this has just profound implications for a patient's dignity, their social life, their quality of life. It's a really sensitive issue.
What usually causes it?
It often stems from damage to the structures that maintain continence. Think the anal sphincter, maybe from childbirth trauma or just weakening with age.
Nerve damage, too.
Nerve damage, definitely. Or conditions like stroke, MS. And interestingly, chronic constipation can actually be a cause.
How does that work?
Well, you get this hard stool impaction, and then liquid stool just sort of seeps around it. So it looks like diarrhea, but the underlying problem is constipation.
Huh. Okay. And for nurses, a key clinical point you mentioned is telling the difference between incontinence-associated dermatitis, or IAD,
Right, the skin damage from the stool itself.
and a pressure injury. They can look similar initially.
They can both present as redness or breakdown, yeah.
Yeah.
But the cause is different, so the interventions need to be targeted correctly. IAD needs moisture management and barrier protection. Pressure injuries need pressure relief.
Makes sense. So nursing management for incontinence focuses on skin integrity and trying to restore some predictability.
Exactly. Requires a really sensitive assessment. Using tools like the Bristol Stool Scale helps describe the stool consistently. And then implementing bowel training programs.
What does that involve?
Things like scheduled toileting, maybe after meals, using fiber supplements to bulk the stool, sometimes suppositories or digital stimulation to trigger defecation at a planned time.
And if it's really liquid stool?
There are specialized stool management systems like pouching systems that can contain it and protect the skin.
Mhm.
But huge caution here.
Yes.
Never use standard rectal tubes or urinary catheters to manage stool. They weren't designed for it and can cause serious mucosal injury or perforation. Always use devices specifically designed for fecal containment.
Critical point. Okay, let's flip the script again to constipation. Fewer than 3 stools a week, straining, feeling incomplete. It's a symptom, but a common one.
Very common. And the main risk factors are often things we can influence. Low fiber diet, not enough physical activity, ignoring that urge to go.
Medications too, right? Opioids are notorious.
Absolutely. Many drugs contribute. And from a nursing standpoint, one of the biggest aha moments, I think, is understanding the danger of the Valsalva maneuver during straining.
Explain that a bit more.
When a patient bears down really hard, it increases intrathoracic and intra-abdominal pressure. This briefly impedes venous return, then causes a rebound surge in blood pressure and heart rate when they relax.
Which is dangerous for whom?
For anyone with heart conditions like heart failure or hypertension or increased intracranial pressure, it can be genuinely risky.
Wow, okay. That's crucial to connect. And beyond just discomfort, severe constipation can lead to hemorrhoids, fissures, diverticulosis, even colonic perforation.
Yes, though perforation is rare, it's life-threatening. So our management is really geared towards prevention and education,
Which means?
advocating for more fiber in the diet, ensuring adequate fluid intake, typically aiming for around 2 liters a day, but you have to adjust that based on their cardiac or renal function.
Right. Can't fluid overload someone with heart failure.
Exactly. And promoting regular exercise. We also teach patients not to put off the urge, maybe establish a regular time each day, often after breakfast when the gastrocolic reflex is active.
Positioning helps too.
It can. Having the knees higher than the hips can straighten the anorectal angle, and just ensuring privacy. And for persistent issues, we might consider laxatives.
What's the usual approach there?
Start with the gentlest options, like bulk-forming agents. Psyllium is a common one. If that's not enough, osmotic laxatives like polyethylene glycol or Laxalus, or stimulant laxatives like Senna or Basacadil might be needed.
Any cautions with laxatives?
Oh, definitely. Especially with older adults, stimulant laxatives can be harsh, and osmotic ones can cause significant fluid shifts or electrolyte imbalances. So start low, go slow, and monitor carefully, particularly kidney function and electrolytes. And we need to educate against chronic overuse, which can lead to cathartic colon syndrome. 2. Acute abdominal emergencies. Rapid assessment and critical intervention.
Okay, we've covered those more chronic, common issues. Let's pivot now to the really acute stuff. Acute abdominal emergencies. This is where quick thinking and assessment are just vital, isn't it?
Absolutely life-saving, potentially. Acute abdominal pain is basically pain that's come on recently and might signal something really serious.
Like what kind of things?
We're thinking inflammation, maybe appendicitis, infection, obstruction, internal bleeding, or perforation of an organ.
And all of those can lead to?
Peritonitis, that inflammation of the abdominal lining, and potentially hypovolemic shock from fluid shifts or blood loss.
Okay, so pain is the main symptom. What else do we look for?
Nausea, vomiting are common. Changes in bowel habits, either diarrhea or constipation. Fever. But sometimes subtle things help, like the patient's position. If they're lying really still, knees drawn up, that classic fetal position, it often points to peritoneal irritation.
Versus someone who's restless.
Right. Someone who's writhing around, can't get comfortable, that might suggest something like a bowel obstruction or maybe a kidney stone, more visceral pain.
Interesting clues. For diagnostics, what's the workup?
It starts with a really thorough history and physical exam. Then labs, typically a CBC to look for infection or blood loss, urinalysis. Imaging is key, maybe an ultrasound or CT scan.
And you mentioned one test that's absolutely critical for a specific population.
Yes. For any woman of childbearing age presenting with acute abdominal pain, you must get a pregnancy test.
Why is that so non-negotiable?
Because you have to rule out an ectopic pregnancy. It's life-threatening and can easily mimic symptoms of appendicitis or other GI issues. It's a classic don't miss diagnosis.
Okay, crucial point. So once you suspect an emergency, what's the immediate game plan? Lewis's usually has those emergency management tables.
Exactly. And the priorities are pretty standard. ABCs first ensure a patent airway, give oxygen if needed, then establish IV access, large bore IVs, usually two, for rapid fluid resuscitation.
Draw bloods, insert a Foley catheter, maybe an NG tube for decompression.
Yes, all of that. And keep the patient NPO nothing by mouth because surgery might be imminent.
What about pain medication? Patients are often in agony.
It's a balancing act. We absolutely need to treat their pain. But the concern is giving too much opioid analgesia before a definitive diagnosis, as it could mask important signs like rebound tenderness that the surgical team needs to assess.
So use it judiciously, monitor closely.
Precisely. Careful titration and frequent reassessment.
Okay. What about abdominal trauma specifically?
We generally categorize it as blunt trauma. Think car crashes, falls, direct blows, or penetrating injuries like stabbings or gunshot wounds.
And the risks differ depending on the organs involved.
Right. Injury to solid organs, like the liver or spleen, carries a high risk of massive hemorrhage and rapid development of hypovolemic shock.
Whereas hollow organs.
Injury to hollow organs, bladder, stomach, intestines. The big risk there is leakage of contents into the peritoneal cavity, leading to peritonitis and sepsis.
What are the telltale signs of abdominal trauma we look for?
Obvious things like penetrating wounds, of course, but also guarding or splinting of the abdomen, a hard, distended feel, decreased or absent bowel sounds. Bruising is key too.
Like the specific patterns?
Yeah, the Cullen sign that's bruising around the umbilicus or Gray Turner sign, bruising on the flanks. Both can suggest retroperitoneal bleeding, which is bleeding behind the abdominal lining.
And a critical nursing intervention if you see an impaled object.
Do not remove it,
Why not?
because that object might actually be plugging a hole in a major blood vessel or organ. Removing it in the field or ED could lead to catastrophic hemorrhage. Stabilize the object in place and wait for the surgical team. 3. Chronic GI management, cancer and ostomies. Sustained care.
Okay, that covers the acute emergencies. Let's shift back now to conditions needing more long-term sustained management. Chronic inflammation, cancer, and ostomies. Let's start with inflammatory bowel disease, IBD. This is a huge topic for students.
It really is. And the first hurdle is understanding that IBD isn't one disease. It's primarily two distinct conditions: ulcerative colitis, UC, and Crohn's disease.
And knowing the differences is crucial for care, right?
Absolutely. They both involve chronic inflammation, yes, but where and how deep that inflammation goes is different.
So break it down for us. Ulcerative colitis.
Think of UC as more superficial and continuous. It's limited only to the colon and rectum, starting distally and spreading proximally in a continuous pattern, and it only affects the innermost lining, the mucosa.
Okay, like a surface inflammation.
And Crohn's.
Crohn's is patchier and deeper. It can affect any part of the GI tract from the mouth all the way down to the anus, though it most commonly hits the end of the small intestine and the beginning of the colon.
And you get those skip lesions? Exactly. Areas of healthy bowel interspersed with inflamed areas. And critically, Crohn's involves transmural inflammation. It goes through all layers of the bowel wall. This leads to those deep ulcers, fissures, sometimes giving it a cobblestone appearance on endoscopy. And because it's transmural, Crohn's is much more likely to cause complications like strictures, fistulas, abnormal connections between organs or to the skin, and abscesses.
Clinically, how do they present differently? Both cause diarrhea, pain, weight loss.
Yes, those are common to both. But with UC, you're much more likely to see significant bloody diarrhea and tenesmus.
That feeling of needing to go constantly.
Right, that rectal urgency and pressure. With Crohn's, because it often affects the small intestine where absorption happens, you might see more profound weight loss and nutritional deficiencies due to malabsorption.
And the complications can be severe for both.
Definitely. Hemorrhage, perforation, strictures. Toxic megacolon is a dreaded complication, more common in severe UC. Fistulas and abscesses, as we said, more common in Crohn's. And long-term, both increase the risk of colorectal cancer, and Crohn's also increases the risk of small bowel cancer. Plus, there are extraintestinal manifestations problems outside the gut, like joint pain, skin lesions, eye inflammation.
Is there a cure?
Unfortunately, no cure for either currently. Treatment is all about managing the inflammation, controlling symptoms, correcting malnutrition, preventing complications, and improving quality of life.
The medications have evolved a lot, haven't they?
Tremendously. We still use foundational drugs like aminosalicylates, especially for UC, and corticosteroids for flares. Immunomodulators help maintain remission. But the real game changers have been the biologic therapies.
What do they do?
They're highly targeted. They block specific proteins involved in the inflammatory cascade like TNF-alpha or integrins that help inflammatory cells get into the gut tissue.
But they come with risks.
Significant risks. Because they suppress the immune system, there's a higher risk of serious infections, including opportunistic infections like TB. There's also a potential increased risk for certain cancers, and infusion reactions can occur.
So what's the nursing implication there?
It requires really careful patient screening before starting therapy, checking for latent TB, hepatitis B, etc., and then ongoing monitoring during treatment. Patient education is huge, teaching them to recognize and report signs of infection immediately.
What about surgery?
For ulcerative colitis, surgery can actually be curative. Removing the entire colon and rectum, a total proctocolectomy, eliminates the disease. Often, they can create an internal pouch, like an ileal pouch anal anastomosis or IPAA, to maintain continence.
But for Crohn's?
Surgery in Crohn's is usually just for complications like strictures, fistulas, or abscesses. It doesn't cure the disease because it can recur in previously unaffected areas of the bowel, and repeated surgeries carry the risk of developing short bowel syndrome.
Nutrition is also a cornerstone, right?
Absolutely. Especially during flares, patients might need bowel rest, sometimes with nutritional support. Enteral nutrition tube feeding is generally preferred over parenteral nutrition, or IV feeding, if the gut is somewhat functional.
And diet modifications.
It's very individual. High-calorie, high-protein diets are often needed to combat malnutrition. Identifying trigger foods is key. Keeping a food diary helps. Many find avoiding high FODMAP foods beneficial.
Okay, let's shift from chronic inflammation to colorectal cancer, CRC. You mentioned a concerning trend.
Yeah, the incidence is unfortunately rising in younger adults, those under 50. The exact reasons aren't fully clear, but links to diet, obesity, and sedentary lifestyles are suspected.
How does CRC usually develop?
It typically starts as a polyp, specifically an adenomatous polyp, which is a benign growth on the colon lining. Over time, sometimes years, these polyps can undergo changes and become cancerous.
Which underscores the importance of screening.
Absolutely. Screening is key because it allows us to find and remove these polyps before they turn into cancer.
What's the standard recommendation?
For average-risk individuals, screening should start at age 45. The gold standard is a colonoscopy every 10 years.
Why is colonoscopy the gold standard?
Because it allows visualization of the entire colon, and crucially, polyps can be biopsied or removed right then and there during the procedure. It's both diagnostic and therapeutic.
Are there other screening options?
Yes, things like flexible sigmoidoscopy, CT colonography, and stool-based tests like high-sensitivity fecal occult blood tests, FOBT, fecal immunochemical tests, FIT, or stool DNA tests are also options, usually done more frequently. But a positive result on any of these typically requires a follow-up colonoscopy.
And people at higher risk need earlier or more frequent screening.
Definitely. Those with a strong family history of CRC, personal history of IBD, or certain genetic syndromes like Lynch syndrome or FAP need a much more intensive screening schedule.
What are the symptoms of CRC? Often late, right?
Unfortunately, yes. Early stages might be asymptomatic or cause vague symptoms like fatigue or unexplained weight loss. Later signs depend somewhat on the location. Right-sided colon cancers often present with iron deficiency anemia due to chronic slow bleeding. Left-sided cancers are more likely to cause changes in bowel habits, like narrowing stool caliber, constipation, or obstruction, and might have visible bright red blood in the stool, known as hematochezia.
Treatment usually involves surgery.
Surgery is the primary treatment for potentially curable CRC. The goal is complete removal of the tumor, adjacent lymph nodes, and ensuring clear margins. Depending on the location and extent, chemotherapy and/or radiation might also be used, either before or after surgery. Targeted therapies are also becoming more common for advanced disease.
And sometimes surgery results in an ostomy.
It can, especially for rectal cancers located very low down near the sphincter muscles. An abdominal perineal resection, or APR, involves removing the rectum and anus and results in a permanent colostomy. Other procedures aim to preserve the sphincters.
Which brings us to ostomy care. This is a huge area for nursing.
Huge. An ostomy is that surgically created opening, the stoma, on the abdomen for waste elimination, and nursing care starts before surgery. Psychological preparation is vital, helping the patient understand what to expect, addressing fears and concerns, and critically, working with a wound, ostomy, and continence nurse, a WOCN, to select the best stoma site.
What makes good site?
It needs to be on a flat surface, away from folds, bones, or scars, so the pouching system can get a good seal. It should also be visible to the patient so they can manage their own care, and ideally within the rectus muscle for support.
Post-op, what's the priority assessment for the stoma?
Color, color, color. A healthy, viable stoma should be rosy pink to red and moist.
What are the warning signs?
Pallor, dusky blue, or purple discoloration, or blackness, indicates compromised blood supply that's an emergency requiring immediate surgical notification. Some edema is normal initially, but it should decrease over time. Slight bleeding when touched is okay, but frank bleeding isn't.
And the output differs between an ileostomy and a colostomy.
Significantly, ileostomy output coming from the small intestine is liquid to pasty and continuous. Volume can be high initially, putting patients at risk for dehydration and electrolyte imbalances.
Colostomy output.
Depends on the location. A sigmoid colostomy, near the end of the colon, might have fairly formed stool, similar to a normal bowel movement, and may even be manageable with irrigation for some patients. Output from more proximal colostomies will be looser.
Ileostomy patients need specific dietary advice too, right?
Yes, because the small intestine is narrower. They need to chew food thoroughly and be cautious with high-fiber or indigestible foods like nuts, seeds, popcorn, corn, and some raw vegetables, as these can cause a blockage or obstruction.
Beyond the physical care, the psychological adjustment is massive.
It's huge. Body image changes, fear of leakage, odor concerns, impact on intimacy. It affects every aspect of life.
So what's our role?
Providing accurate information, teaching self-care skills, offering unwavering emotional support, connecting them with resources like WOCNs and patient support groups like the United Ostomy Associations of America, helping them see that a full, active life is still possible. Addressing concerns about sexual function openly and providing resources is also key. Other common lower GI conditions, hernias and hemorrhoids.
Okay, almost there. To wrap up, let's quickly touch on a couple of other common conditions you'll definitely see. Hernias, for instance.
Right, a hernia is just a protrusion of tissue or an organ through a weak spot in the abdominal wall. The main worry is strangulation.
Explain that.
An incarcerated hernia is one that can't be pushed back in. If the blood supply to that trapped tissue gets cut off, it becomes strangulated. That leads to tissue death, gangrene, and is a surgical emergency causing severe pain and signs of bowel obstruction.
Most common type.
Inguinal hernias in the groin area are the most common overall, especially in men.
How do they present?
Usually as a visible bulge, maybe some aching pain, often worse with activities that increase intra-abdominal pressure like lifting or coughing. Severe pain suggests incarceration or strangulation.
Treatment is usually surgery? A herniorrhaphy?
Yes, surgical repair is common, often done laparoscopically as an outpatient procedure.
Key post-op nursing care?
Monitoring for urinary retention is important, especially after inguinal hernia repair. Managing scrotal edema with ice packs and scrotal support. Teaching patients to splint the incision when they cough or deep breathe, and encouraging deep breathing but often restricting forceful coughing initially. Activity restrictions are also important to prevent recurrence while healing.
Okay, and finally, let's talk hemorrhoids. Very common, often uncomfortable.
Extremely common. They're just dilated, swollen hemorrhoidal veins, either internal inside the rectum or external under the skin around the anus. Usually caused by increased pressure from straining during defecation, pregnancy, prolonged sitting, or heavy lifting.
Symptoms differ for internal versus external.
Generally, yes. Internal hemorrhoids often cause painless, bright red bleeding during bowel movements, maybe some prolapse. External hemorrhoids tend to cause itching, burning, and if they thrombose, form a clot, they become very painful.
What's the usual pair?
Conservative measures are first line. Increasing fiber and fluid intake to soften stools and prevent straining. Sitz baths can soothe discomfort. Over-the-counter creams or suppositories might provide temporary relief.
And if those don't work?
There are procedures like rubber band ligation for internal hemorrhoids or surgical removal, hemorrhoidectomy for severe or thrombosed ones.
And post-hemorrhoidectomy nursing care. That first bowel movement can be rough.
Oh, absolutely. Pain control is the absolute priority. Often involves multimodal analgesia, maybe opioids initially, plus NSAIDs, plus topical anesthetics. Giving pain medication before the anticipated first bowel movement is crucial. Stool softeners are essential to prevent straining, and continuing sitz baths for comfort and hygiene. Outro.
Wow. Okay, we have covered a lot of ground today, from diarrhea and constipation all the way to IBD, cancer, ostomies, and more. So bringing it all together, what's the big takeaway for nursing students listening?
I think it really highlights the interconnectedness of everything, doesn't it? And the sheer breadth of the nursing role in GI health. Yes, understanding the pathophysiology is the foundation. You need to know what is happening.
But that's not enough on its own.
Not at all. The real core of nursing is applying that knowledge through the nursing process. It's your assessment skills catching those subtle signs. It's your ability to prioritize what needs to be done now. It's collaborating with the team. And it's that crucial patient education piece.
Making the difference in how patients manage these often chronic and challenging conditions.
Exactly. And always remembering the individual patient experience. These conditions impact people's lives profoundly, far beyond just the physical symptoms.
Absolutely. The GI tract really is a window into overall health, and these conditions deeply affect daily life, dignity, and well-being. As you keep learning, keep practicing, remember that every detail matters. Every assessment finding, every intervention, every bit of teaching you do can be a crucial piece of the puzzle.
So keep asking questions.
Keep making those connections. What new insights will you gain as you apply this knowledge? Not just seeing the disease, but truly seeing the person experiencing it.
Well said.
Thank you so much for joining us on this deep dive today. Keep learning, keep questioning, and keep making that difference.